To finish out our first day of plenaries is a panel discussion on DHA health and digital integration. The panel features Rear Admiral Tracy Farrell, MHS Genesis Functional Champion, Colonel Tora Connor, DHA's Chief Health Informatic Officer, and Dr. Jesus Caban, DHA's Chief Data Analytics Officer. Please welcome them to the stage.
Good morning. Do I have slides? Oh, there it is. I won't murder you with slides, and I'll be brief because what I really want to get to is having a discussion with Colonel Connor and Dr. Caban. As Dr. Deal mentioned, they are incredible partners. I wouldn't be in any other foxhole without them. Appreciate the work that we get to do day to day, so I want to say thank you as well. Dr. Deal, great people, and I would say the same thing about the folks that Dr. Deal mentioned earlier. Without the partnership and the working together and that great relationship, achieving success would be truly challenging. So with that, so DHA health and digital integration, as was mentioned, number one, I'm not a computer scientist nor a interventional radiologist, nor am I a math whiz, but I have the true honor of being able to support really the improvements in the digital space within our organization to hopefully advance what's available in technology with partnership with our PEO DHITS folks. Really appreciate you all and the work that we do together, but also with our industry partners. It's really critical that we look to see what advantages are available to the military health system so that we can defend and protect the nation and keep our folks safe. So thank you all for that partnership, and I truly do look forward to any of the advancements that we continue to make. Most of you that work with me know that I want everything yesterday. And I look at Colonel Connor because I will always challenge her, but can't we automate that? Can't we do that? And she'll look at me and she'll go, ma'am, ma'am, I don't think we can get there anytime soon. I say that so that you all know that I am a true advocate for those at the deck plate that have to really be challenged with the day-to-day business of delivering health care. The more we can do to support that, the more we can do to remove the administrative burden and allow them to see patients to take care of people, the better off we are as an organization. So my advocacy and my role as the functional is really to achieve that. So I really have the unique opportunity to help support those initiatives. That's us. I wanted to show you this just so that you all can see, really, in partnership with PEO, the Herculean work that's been done and completed, I believe as of March last year. We have, the Genesis has been deployed to multiple locations, not only within the military health system, but also with our Coast Guard partners, as well as the VA, and NOAA. So a lot of work to deploy a longitudinal record, a federal healthcare record globally, to be quite frank with you. And I had the distinct opportunity last week to visit Poland at one of our operational sites there. We had, and they're not included on here, I don't think, because it's a more recent deployment of the Genesis remote capability to that site. You know, it makes a true difference when you visit some of these locations and you understand truly what the challenges are that they face, where they are located, what's available to them. So what a great opportunity to go out and see what we were able to turn on for them to hopefully support everything that they need to do to keep us safe. I can't say enough about the folks at the MTFs in the different locations that support healthcare delivery. I visited many locations to understand the true challenges that they're experiencing. I can say that Genesis is a great tool. I think it has capability beyond what everyone really truly understands and has tapped into. But I think and I always say this, I think we can do better. They deserve better. And I think in partnership with industry, with PEO, and all the great men and women who serve, we'll be able to give them better with a lot of the emerging technology, the advancements that are being made on a daily basis. When I was at DHITS last year, we were right on the cusp of a lot of great technology that the civilian sector has started implementing. The advancements that's been made just in 1 year is incredible to me. I want to move at a pace probably that we cannot achieve today, but I see that there is a sense of urgency with our current leadership to be able to automate and make technology available, not only in the healthcare system, but in the military system itself. So just wanted to show this and say thank you to everyone that was involved in the deployment of Genesis. Dr. Weber, Dr. Sheets, you and your teams have been incredible, and I'm honored to be a partner with you all. So in the last year, Dr. Deal mentioned digital strategy. And so we discovered early last fiscal year that we needed a pretty robust digital strategy and nesting under Ms. Orsega's transformation strategy, where it relates to the digital strategy. We discovered we needed to have a digital integration model at DHA that would support the entire organization. And this is just kind of an ecosystem of who's part of my immediate responsibilities and partnerships. So within the digital integration office, we have health informatics, which is led by Colonel Connor, as well as the CDAO, which is led by Dr. Gaban, and we work very closely together. We're truly a three-legged stool. Working with J6 to make sure that the systems support everything that we do, and then again with the PEO partners, not only DHIMS, but EIDS and JOMIS. There's a lot of work being done on that front, and we work very closely with them. And those partnerships are truly critical to the success of what we are doing in employing technology and improving and optimizing the current record. Not on here is acquisition. I work very closely with Ms. Burst, kind of connected at the hip with the digital strategy and acquisition strategy go hand in hand. We've done a lot of work to rationalize what our digital portfolio looks like. It's an incredible footprint. I think we've been able to rationalize that. We are prioritizing. I know there was a question about funding, so we're looking at the requirements and really trying to invest where we see our greatest amount of return on that and the biggest changes that can be made through that digital portfolio. So thank you, Ms. Burst, for that partnership, and I look forward to successes along the way with that. So we have developed this digital integration team, and I'm truly honored to be a part of that team. Oh, I went backwards. Maybe. Did I lock it? There we go. Okay, and this is really where I wanted to get so that we could have really good dialogue of where we are today and truly where we're going, not only with MHS Genesis, but also with our digital strategy and our efforts associated with big data and data governance and some of the technology that we believe that will be made available in the very near future. And I'm going to turn to my esteemed colleagues and sit with them and really talk through some of the where we are and where we're going, and then we'll take some questions from anyone that has some questions. So with that, I know Colonel Connor and Dr. Gaban, we've done a lot of work together over the past few months. Tara, you and I for probably the past year, really focusing on where we can go with really our end user experience, our data models, where we can apply innovation and emerging technology. And Tara, I'm gonna kind of put you on the spot. You came about a year ago, a little over a year ago. We had rolled out Genesis, and we were right in the middle of advancements in technology, optimizing the record. Can you give us kind of your synopsis of where we are today and where you see us, not only in 2 months, 6 months to a year?
Yes, ma'am. I think for us, the balance is really looking at what can we do with the technology today to improve what we have. So I would say that's kind of our now. So every week we put out updates to the system. Hopefully you all are getting the notifications on what those updates are. But those are kind of the smaller configurations where we're improving a power form for data capture, we're improving an M page for clinician documentation experience, or we're improving potentially the coding capture, for example. And then there's the near, and I would say that's where we're really looking at initiatives that we think can have a high impact, and so those are the new capabilities. So, of course, taking priorities from our functional leads and from Admiral Farrell, we kind of have a list of really what those capabilities are that we would like to adopt in the near future that we think will have a relatively significant impact. Most of these are commercial off-the-shelf products, so it's things like the ambient listening, messaging capability within the system, and that's within the MTF level, but also across the enterprise, really to be able to improve kind of our communication globally and really take advantage of the fact that we are a global military health system. And then additional capabilities like looking at dashboarding for things like bed status. I'll probably touch on that in this conversation at some point because we hear about it every single day, and of course we had a question about it a few minutes ago. So a list of new capabilities, and then the future, and that's really looking at where can we get with AI. So the future EHR really is going to be, I think, centered around AI and really fully AI enabled. We're not there yet, so we have to continue to optimize what we have today, which means making sure that we have a way to capture the data that we want, a way to measure it, and a way to monitor our compliance.
No, thank you. So related to some of those capabilities, I know you mentioned bed status, and I know that was a question, and I think that'll also go hand in hand, Dr. Gabon, with some of the capability and the interoperability we're pursuing, not only within the military health system, but also with our federal partners, as well as potentially with the civilian network that can help support during times of conflict or crisis. I know you mentioned bed status, so I want to hit that because I think there's a capability today that we could optimize that will probably propel us into the ability then to tap into some of the data. But am I understanding that correctly, Tara?
Yes,
And then I'll turn it over.
I think to go back to the previous slide where we showed all our stakeholders, as the question came up, I was thinking through, I really think this might be one of the best use cases to illustrate, honestly, the partnership between all of our stakeholders. So to be able to see ourselves, there is a capability within MHS Genesis called capacity management, which is how we see bed status. We're really going to have to partner with HCO for policy on the use of that tool. We are going to be responsible for making sure the foundation is built, that our beds are built correctly so we can capture the data. We're going to have to partner with J6 to get the devices that we need our nurses to use and our environmental services teams to use to be able to capture the status of those beds. And of course, the nursing community to be able to really lay the foundation and emphasize the importance of utilizing that capability. All of that just gets us to being able to see ourselves. We know that for kind of these future scenarios that we've got to be leaning towards as a combat support agency, we also need to be able to see what's available within our networks, and that's CONUS and OCONUS. And so that's where The data and analytics office, EIDS come in, where we've got to pull in all of those various data streams, and I know Dr. Caban can go into details on that. He just showed me a very complex graphic of where all that data comes from. And then we have to be able to show it and make it visible to our combatant commanders and the folks who are really going to need it, which is where we need to partner with JOMIS. So absolutely, we all have to be able to work together to make sure we capture that data accurately, we pull it together, and we present it to the people who need it in a way that's digestible and usable in real time.
So Dr. Caban, on that same note, what are your thoughts in the foreseeable future for us to be able to really tap into that big data that we spoke about earlier, not only probably related to bed status, because I think that's going to be key to our combatant commands to see, but other elements. I know you've been working not only with EADS, but alongside some other efforts. Could you share that?
Sure. So bed status is just one of the use cases, many use cases that we have. So going back to actually a number that Dr. D was mentioning, 738 days. So the first time I met with the new chief of staff for DHA, Major General Brenner, yes, it was a very simple meeting. He asked me to go to his office, and it was 750 at that point. And it was simple. It's like, Jesus, 750 days as the Chief Data Analytics Officer for DHA, how are we going to be ready? I need to see the plan because we need to mature in this space. So one of the use cases, as it was mentioned before, from our combat support agency for sure, is the bed status. The data from bed is not only Genesis. That's one of the sources, and Colonel Connor mentioned the different steps and initiatives that she needs to take to make sure that it happens, that we have that data. But there's data in the MIP, there is data in Genesis, in the MIP, there is data in Traces, that is the official source that they use for bed status. There is data in JOMIS systems. There is data in the VA that we need. There is data from TRICARE. So many different sources to be able to come up with that picture about just that use case. But we have many, many use cases. So for me, what has been the priorities? We have, as Mr. Flinder in his slide he showed, I took it here. He talked about the 4 enterprise data centers. He mentioned about 16 regional data centers, the multi-cloud environment that we have, either Azure, AWS, GovCloud, or Oracle Cloud, and so on. All of them have data. So the first priority that we need to have is to be able to mature in the data. To be ready in those 738 days, we need to mature in our data analytics space, and that starts by having a complete inventory about what data we have, who is the data owner, who is the technical steward, and so on. So that's the key initiative, first initiative that we have to make sure the use case for bed status, we can get there.
Thank you. I think also important along those lines to the combatant commanders in not only the bed status, but being able to track all of the patients, to know where all of our folks are located. So I think the sooner we get there, and I know that's a strong initiative, not only with your conversation with General Brennan, but I know that's the really goal of the department, is to be able to tap into the data from all areas within the military system to be able to support the combatant command. So thank you. I really appreciate that. Also on here, we spoke about innovation. I know that Dr. Dill mentioned Dr. Freeman's efforts, and truly that whole team that's worked tirelessly to implement new tools, technology, but also processes within the military health system. And so there's, we over the last year and a half, we put out new virtual capability in scheduled virtual visits to be able to see any patient that desires to remotely, to be able to care for them at remote locations through this technology, as well as other technologies that we're looking into to support our patient population, working closely with Ms. Julian in healthcare operations on how we can really capitalize and optimize the availability of the capacity of our military health system to increase access to care. So I know that SVV's one innovation that we've implemented, and there's others that we are pursuing. I know that not innovation, but probably optimization through the record itself. Colonel Connor, I know something new that's coming and should tie into some of those efforts is the patient portal and the advancements and the improvements that are coming with that. I know there's capability today that I believe that a lot of our beneficiaries don't understand, but if you could just share some of the improvements that are coming in that space.
Yes, ma'am. One of the things Admiral Farrell's really done for us is give us priorities from the functional leadership. So I often say to folks, we never have a shortage of work, so we absolutely need that prioritization. And a new patient portal, we have heard you all, is really one of the top priorities that we've been partnering with DHITS on. And Oracle Health does have a new patient portal coming. It is currently generally available, and then we have it on our top priority list to hopefully implement within the next, I would say, year or so, I hope is a realistic timeline. Some of the things we're most excited about with that, there's capabilities within the new patient portal that are very kind of proactive for population health management. One of the things we've really struggled with our current portal is just kind of the user experience with scheduling and messaging and kind of finding your clinic. So with the new patient portal, you actually can favorite your providers that you want to communicate with and schedule with, which will hopefully make that a much easier experience. There's also care team scheduling. So we know that a lot of our primary care teams do function as teams, so you can be able to kind of cross-book with a partner. And so that capability does exist within the patient portal as well. One of the things I might be most excited about is actually the ability to self-register if you have OHI. So it'll have the capability to kind of scan a health insurance card and capture that information. And then the follow-on to that is actually self-check-in. So really trying to offload some of that work that's done at our front desks. We know that for many of our front desks, they don't necessarily have permanent staff. A lot of times it's whoever's available to check in the patient. It's really a critical step in the clinically driven revenue cycle. But when you have kind of a transient population, it's difficult to get good adoption of the workflows that really need to happen at that front desk. So the more we can automate, the more we can have our patients participate, I think the better it'll be. So that's what's coming. And then it doesn't mean we've stopped. So we certainly are still working on some of those challenges that we have with our current patient portal. There's options for making the patient name that's visible to the patient for the clinics more friendly for them. And so we're working with sites on improving that naming convention and also some scheduling optimization.
No, thank you. Appreciate that. Also, in the last year, we have stood up the CDAO office. I think that's been a true need at our organization in standardizing and really improving the quality of data that we are making decisions on. Dr. Gabon, can you share some of the efforts that you've implemented or still underway that are part of your responsibility as the CDAO and what that means to us, not only in the healthcare system, but also in partnership with industry, if you could?
Absolutely, ma'am. So going back, when Mr. Freinder was talking, he mentioned some of the initiative that he has, Zero Trust. He mentioned about patient access management and other initiatives. But also what you will be hearing a lot, it is, yes, we have data modernization initiative. Why? As I mentioned before, we need to mature in this space of data. There's data all around the organization. And so we need to come up with a strategy. First, the strategy, we're part of the DoD. So we need to match effectively with the DoD data strategy of making the data more visible, more accessible, more understandable, and so on. So 3 of the core initiatives that we are running as fast as we can with them is first the inventory that I just mentioned. Who has the data and where? What is the meaning of the data? Second one, it is governance. Who owns the data? Who is the point of contact? If I need to know this piece of information about blood expiration date across the agency, who is the person that knows the most about that? Who is the person that knows the most about in the medlog, all the logistics? In the HR space, who owns the ATAP's data, an Army system, and so on. So if you look at DHA as a whole, even though under J6, there's about 50, 51, 52 systems, all around the organization we have data systems generating data. So we need to make sure that in a distributed, complex environment, we can implement effective data governance. And the third one, it is data literacy. We need to understand the value, make sure every single individual, regardless they're at front desk in the MTF, or they're in headquarters, or they're in the United States, or they're abroad, they need to understand the value of the data. So we're doing a lot in the data literacy space, analytics space, because, for those of you, 123 CIOs out there under DHA, we need to make sure each of you, your deputies, and so on, understand the value of the data. Those servers that you have in the basement of the hospital that have data, they might have very valuable information. So by doing data literacy and so on, people will start being more transparent about the data. People will start being more like who to access, who to have the information about what data and so on. So that's how we are very quickly will be maturing in the data analytics space.
Thank you. And I know, Tara, Colonel Connor, you mentioned AI, and I know there's a sense of urgency not only within the Digital Integration Office and with Genesis and with our PEO, the advancements that are being made with AI and the ability that it has and the responsibility, I think, is the other key piece of that. I know that there are a lot of our end users that are trialing different AI tools that are out there. I'm kind of curious, and I know the answer to this, but I really want to hear you all's perception of the risks and the benefits of not just AI. I think there's definite benefits, but where do we need to be more cautious with the health record and the tools that we're putting against the health record that are available probably in OpenAI, if you will, and how that's translating over and being utilized in the record. And Tara, that's for you. And then Dr. Gabon, what are we doing in the AI space, or what should we be doing to ensure that we're observing the right protocols and governance over AI?
Yes, ma'am. I think the biggest thing we, of course, always have to consider is protecting our data, our PHI and PII. So I'll start there. The other thing is, I would say the ideal end state is that whatever we use is going to be fully integrated with the electronic health record. One of my biggest concerns about the tools that we're hearing about is that they're not integrated. So we run the risk of generating a lot of free text. Free text, at least at this point, is often not able to be computable data, and so we're not able to use it in the way that we want to. And I do have concerns about then the integrity of the patient record. We really owe it to our patients to have certain things. We call it the PAMPI data, but problems, allergies, meds, procedures and immunizations captured discreetly, so that we can make sure that those are a permanent part of their record, they're easy to find, and they're where clinicians expect to find them. So when notes are generated outside of the electronic health record and then essentially copy and pasted in, those become free text notes, and we lose that discrete data at this point. The capabilities that we're pursuing will be integrated with the electronic health record, so that we can have that discrete data where it's appropriate. So I think those are my two biggest concerns about kind of pursuing it outside of Admiral Farrell's efforts, the digital integration platform, really making sure that it's integrated within the system that we use today.
Thanks.
So that's a difficult question.
Yes.
Interesting enough, even though I have been doing machine learning for, as a computer scientist background, doing this, the definition of what is AI, what is machine learning, how to use it have evolved, right? In 25 years ago, 2000, I was taking the machine learning class at that point, and doing perceptrons and so on. That's basically the back end of machine learning, predictive models and so on. It has evolved. Why? Because the technology is moving very fast on one side, and also the hype and buzz is also moving as fast. So what are we doing, across the agency? We are doing a lot. We're doing a lot of pilot projects. See how I mentioned pilot? Because as a report that many of you have seen or heard from last week from MIT, 95% of the projects are failing, right? You go and find the report that came out last week. Because we are trying to move fast, saying, okay, I have this large language model, let's implement it, let's do it there, and it's not generating any. If it's not fully integrated, it will not be used. If it's not completely aligned with the business value, the priorities for the organization, it will fail. So, yes, we're doing a lot of work, but more importantly, we need to step back and consider our priorities. For example, ambient dictation, coding, and so on, before we just jump and start using it, because then it will fail. But yes, from the policy point of view, we're working very closely with Health Affairs, and tomorrow morning in this stage, you will hear from Ms. Ursega from Health Affairs, the amazing work that Health Affairs is doing to make sure we have the AI policies and governance framework in place to expedite that adoption. And also, we're working very closely with the DoD CDAO office to make sure we align everything that we are doing with what the DoD Pentagon CDAO is telling us, the capabilities and the guidance that they're providing. So a lot is happening in this space, but for me, for most of you have been in the conference, I started hosting the AI Machine Learning Annual Conference in 2018. That's 7 years ago. I kind of stopped already doing that. But you have seen how my motivation, energy about machine learning have evolved. Is because, yes, we need to use it. I use it, but we need to be responsible about it. We need to be very careful about it, and we cannot overpromise.
No, thank you. A lot of great details shared. In my role as the functional, really evaluating requirements, putting a priority against those, and working with our requirement sponsors, really key. Some of our top priorities, and we've mentioned these a couple of times, is the ambient listening. So that will generate a note for providers, and there's other capabilities that can also be coupled with that will support the delivery of healthcare and automating some of those processes, the administrative burden that a lot of our clinicians experience in delivering care. So number one priority. Another priority of ours, working with our partners with Dr. Weber and Dr. Sheets, is the the coding and the auto coding capability and how that can support our business side of healthcare delivery so that we can capture all the great work that's being done within our military health system. Also being able to get cost accounting and reimbursement for that. So pursuing very aggressively, I will say, those two capabilities. Those are our top two priorities. Not only does it improve safety to our patients, but it also provides a quality of care that sometimes is sacrificed really at the expense of administrative duties. So we want to make sure that we free up the clinicians to be able to really pay attention to the patients, capture all that information. But also along those lines, we've seen some great emerging technology that's coming. It's not available to us, and I don't even know how much it's available in the civilian sector, that there's some predictive capabilities and it can do the assessment on that patient and make recommendations to that provider that's seeing the patient based on all the records that's available, that the AI can go in and actually query as the provider is seeing the patient that maybe was missed the last time or wasn't talked about this time, that will make suggestions and recommendations to the clinician to say, hey, have you asked about, you may be talking about some acute illness, but it will remind you that the last visit they had an abnormal lab or some abnormality that was captured in the note that maybe you didn't cover today just based on the time. So I think there's a lot of capability coming that we've been able to really, we've seen some demonstrations of what it can do. It's not generally available to us, and I don't know that it's available in the civilian sector to the extent that I just mentioned, but I really see great opportunity for the military health system, and not just in garrison. We've been challenged that any of these capabilities that we're pursuing, that we look to see what could potentially be available in theater as well as in the operational environment. I think you introduced some risk with some of that, but we have been challenged by leadership to make sure that we're considering all of this capability across the continuum, and we owe that to all of those that are serving in that capacity to be able to do that. Any thoughts? I'm not putting you on the spot. Any thoughts on that? Tara, I know that we've seen some demonstrations. I know that Oracle Health has things coming, but also industry has some capabilities out there. Any thoughts or communications among your community in the physician world?
I agree with your statements, ma'am. I think the EHR of the future, I think we know will be interactive and AI-based. So it'll give us summaries of our patients. It'll tell us, if we're seeing them for diabetes, it'll give us information on their relevant labs, medications they're on. And so I absolutely believe that we can expect that in the future. And then in the meantime, it's a matter of us kind of looking at what capabilities can we leverage that might give us some of that on a smaller scale. So some of the tools that we're looking at, and initially it's note generation, but things like patient summaries, potentially proposed orders, just kind of getting a hint at that predictive capability. We do expect some predictive capability within the eTelecritical Care platform. That's an in-progress project at this time. And then I do want to touch on kind of your point on the operational setting, and I really want to emphasize our partnership with JOMIS and really all the progress that team has made, especially in the last year. It's exciting. They're getting very close to being able to really implement their products. And what we expect when those products are deployed is that there will be a complete data flow through, so that from BATDoc through the care delivery platform through Genesis Theater, if it's included in the pathway, all the way up to Garrison, that data will flow through from end to end, and we really truly will be able to have a longitudinal health record, including in the operational setting. So really excited about that, and really appreciate all the work that the JOMIS team's done in the last year especially.
Agree with you. So to that end, with all the potential emerging technology, I know that you have made significant strides in the end user engagement and being able to support really training at the deck plate and informing them of the capabilities that are coming and being able to provide training, real-time training to them. Can you explain a little bit? We're in a resource-constrained environment. I think we're all experiencing that, but I know that your team has really been actively improving the way that we engage with the end users and provide training. Can you speak to that a minute?
Yeah, thank you for the opportunity. Yes, definitely want to acknowledge our end user engagement team that absolutely is trying to make the most of our resource-constrained environment. I know for those of you who are at the MTFs or at the network level, you've felt it. We hear you. We certainly have taken some decrements over the last couple of years, but end user engagement has continued to lean forward and look at really where are there opportunities with the capabilities that we have to really get after that training and adoption. I do want to acknowledge that we know that the buttonology training in the classroom does not get you where you need to be with the system. That over-the-shoulder support and adoption support is really critical to make sure that our end users are adopting the workflows we need them to adopt to capture the data appropriately, to be able to use the data for the reporting and workload capture that we have. So they have stood up something called EHR University. It's available on your desktop as an icon that's really intended to be a one-stop shop for all of our EHR resources. We also, I mentioned early on the weekly updates that we put out in the system. We have continued to struggle with ensuring that our end users and all of you as support team members are aware of what those weekly updates are. We've actually implemented a link within the electronic health record to those weekly updates, so should our end users desire to go look for them, they can find them. And then they're really targeting their education opportunities. So partnering with our functional leads, again, on really where are the pain points, where are the areas and the workflows that we need to focus most on. And they've stood up some webinars that are synchronous, but also recorded, so our folks can go out, our end users can go out and watch those when it's available. So I think one of the first ones we did was front desk optimization. And then we've done some provider documentation optimization webinars as well. But really, they're absolutely trying to get after how can we meet the end users where they are with the capabilities we have. We all know we would really love to have a capability where you can be in the EHR and hover to discover and go find the answer to the question you have. We're not quite there yet, but our team is absolutely doing what they can with what we have now. I am going to put a plug in. They're going to be talking about EHRU. I think it's on Thursday at 11 o'clock if you're interested in that breakout session. Thank you for the opportunity.
That hover thing,
Yes.
I asked for that. Could you just like hover over something and it tell you what you need to do? That's the easy button for me.
Yes,
Not
ma'am.
yet. I know she's like.
Actually, I want to add to
Yes.
what Connor was mentioning. Aside from the EHR workflows and so on, we need to find ways to improve the utilization or increase the utilization of the built-in reports in Genesis. Because often, and once again for the CIOs out there and so on, often you will see in your NTF, they come in and say, we need to have this piece of information. And then by default, you find someone in research in your local business ops office and so on to go and use the M2 or the legacy MDR and so on to pull the data. But we need to start changing our mindset. There's over 1,000 discern reports. That's where we always should start. Discern reports in Genesis, they have implemented that, and we continue to work very closely together that if there's new discern reports that need to be updated or added or modified the methodology, that's where MTF should start. Second, increase the utilization of health analytics, also known as HDI. There are amazing capabilities there, a lot of dashboards for the markets and the networks and the MTFs. We need to find ways before we jump and start pulling data and creating our own, dashboard in our Power BI that we have in our desktop. Let's leverage what we have out there. That way, when we have conversations, We know how you pull the data, where the data came from, and so on. So using those capabilities will be critical to continue improvement.
Oh, thank you for that. I want to make sure that we leave some time for questions. I could keep talking about this all day because you brought up something I wanted to mention, but that will take us down a half-hour pathway. A lot of exciting technology and innovation occurring. What I'd like to really make sure that we as a military health system observe is the pace at which technology is advancing in the civilian sector and really using, there's a lot of brain power in here. How do we keep pace with the civilian sector, observing all of those critical cyber protocols that we have to maintain, keeping our data safe? I think we owe it to those that we serve and those at the deck plate, really providing the technology that the civilian partners have. So I would really love for this group of very, very intelligent folks to consider that and how we keep pace with our civilian partners in providing the best healthcare. We're the largest, really globally, health system there, so that comes with its challenges. But I challenge that we, our clinicians, our soldiers, sailors, airmen, Marines, coasties, everyone deserves the best level of care. So I'm really excited about that. I will continue to be an aggressively pursuant of technology for the military health system and be the advocate of those at the deck plate. But with that, we'll pause and see if there's any questions.
There's quite a few, ma'am.
Okay.
We've got time for about 4 or 5, depending on how long the answers are.
Okay.
And if anybody wants to come up, like Mr. Mounts, you're first up.
Oh, I'll defer to you first, Sergeant Price.
Thanks, sir. Quick one, hopefully. Where are we with the automation of referral management and appointing?
That's a great question. I know we have efforts underway, and I'm not going to make a promise that we can't keep. I know that Miss Julian's working with her team and some of the new, the Global Nurse Advice Line in integrating technology within that tool. So there's more to come on that. We're pursuing that. I don't have a solid answer for that, but hope is not a plan, but it's part of our requirement.
Yes, ma'am.
For the Global Nurse Advice Line to automate some of that and integrate that within the record. Did I say that right, Miss Julian? Okay. Okay. And so she will talk a little bit more about that tomorrow.
Yes, ma'am. Mr. Mounts.
Hey, thanks, Sergeant Price. And good afternoon, the three of you, and thanks for the work you're doing. Colonel Connor, thanks for representing the Air Force so well. It's wonderful to see you up there again.
Thank you, sir.
Question, as I look at our total beneficiaries, 9.5 million, and we know that only about less than a third of that actually get care full-time in the direct care system with our EHR. Can you all speak to a little bit of what, if we have a gap, or what that might look like in the way of a complete record on all our beneficiaries? And really, the active duty component of that's a big deal. You know, we send a lot of care downtown, and we have to complete the record, et cetera. But for all of our beneficiaries that are not connected to direct care at all, you know, do we have an idea of what their health record status is, or do they have one when they come back and forth into our system, if that makes sense? So, or what we might be looking at to complete that data set, if you will, in the future. Thanks.
Yes, sir. Especially with the new patient portal, one of the points of emphasis is to have that comprehensive health record. This isn't specific to the military health system, but for patients who use that patient portal, for them to be able to see records from outside providers, including other providers that use different EHRs. So that's absolutely a priority for the new patient portal. I do also want to acknowledge that we have our legacy EHR data. So that is a project that was previously in progress. It's kind of on pause at the moment, but we anticipate sort of reinvigorating that as we stand up the new patient portal to look at opportunities to pull in that legacy EHR data into the patient portal so our patients in the future will have data from the legacy EHRs, data from the current EHR, and then as well as all of their records from any of their civilian healthcare providers.
Thank you. Ma'am?
Howdy. Okay, thank you guys so much for the great talk. You guys talked a lot about standardizing your data so that it could be usable for people caring for these patients, nurses, doctors. Medical data is very unstructured in some places. You mentioned free text. There's also PDFs. There's also scans of x-rays, all that stuff. So I was wondering, what is the pipelining specifically for getting that unstructured data structured and usable for these end use cases?
It's a great question. Oh,
Okay,
go ahead.
so
You wanna-
Thursday at 8 a.m., we have a talk about the MHS Common Data Model. This is in collaboration with EIDS. So yes, we know that standardizing data is very difficult. For analytical purposes, for business purposes, we have been working with EIDS and PODEMs to have a common data model, standardizing all this ICD-9, ICD-10, and ICD-9-CM, ICD-10-CM, and ICD-10-GM, Germany, and so on. We need to put it. So Thursday, 8 a.m., I think it is, we'll be talking for an hour about the specific steps that we are taking to move to a common data model.
Awesome.
Coming
Thank
to
you,
a
sir.
theater near you.
Ma'am?
Hi, Cheryl Ann here again. So many questions, but I've narrowed it down to two that are just, I'm dying to ask you. Admiral Farrell, as the functional champion, you oversee the translation of mission needs into actionable capability priorities. How can the capability management process help you ensure that our functional requirements are prioritized and remain tightly aligned to our warfighter readiness while avoiding duplication across the enterprise in a fiscally constrained environment? And my second question is for you, Dr. Caban, because you know I always love it giving you hard ones. Data is the core enabler of both care delivery and readiness forecasting. What role should management, capability portfolio management, play in helping your analytic teams not only capture the requirements more effectively, but also structure them so that the agency can make an investment decisions that are evidence-based and driven and capability available, enterprise available? Thank you.
I'll take the first part. So related to requirements, the effort underway, and we're maturing the process, is to receive that requirement through various channels, to rationalize the requirement and to prioritize that requirement through a governance process with Mr. Flanders and Ms. Burst to be able to understand the fiscal requirements as well. And so we are looking at all those requirements and rationalizing those based on not only the priorities of DHA, but of the department to be able to achieve that with the resources that we have. So looking at all those requirements, rationalizing that, putting it through the governance process, and then making some deliberate, disciplined decisions based on how it's supporting really our combat support mission as well as the legislative requirement for the benefits. So really putting discipline against that process is where we're at. We're maturing that. We're not quite there, but I believe we'll see significant progress over the next year in being able to achieve that. I hope that answered the question about the capability management. I saw you walk away, but I don't know where you went. Okay, there you are. Okay.
And the part about the second question about data, first, we appreciate very much what the team, the class requirements, and so on, they're doing an amazing job. Get involved. So this afternoon, I had 2 sessions, one repeat, discussing the 8 steps that we're doing to mature in the data space across the agency. Step number 8, we'll discuss collecting requirements and so on. I would love for you and your team to get involved and even take the lead in that, help us define, flush out what we need to be doing in that space to better drive the requirements that you need.
Awesome, thank you, sir. Ma'am, final question.
Hello, I'm Lieutenant Colonel Rapps, the Chief Health Informatics Officer for the 59th Medical Wing. And I have a question, and special good morning to Dr. Caban and Colonel Connor. I have a question more on the tactical level. So on a daily basis, I help patients with patient portal issues. I help providers figure out and commanders pull discern reports. I champion tickets to build new PCLs for different clinics. And I even help senior leadership answer questions on the up and coming AI governance, and do we have a governance, and what is allowed and what isn't allowed. So there's a lot of work, more than what I can actually handle. So from the panel's perspective, with this awesome structure that you have, where you have the health informatics and the data working together, we see it also at the network level. When are we going to start forcing that structure at the MTF level, where we actually have manning to support and address these questions and daily ongoing needs, particularly with all that stuff coming out? What I see is, oh my goodness, how are we going to do all this at the MTF level?
First, before you jump in there, thank you for what you do. I know that, and I've said this to Colonel Connor, we need more health informaticists, so thank you so much for what you do. And I think there's part of the challenge that we experience is we don't have the talent probably within the organization. The pipeline probably isn't producing as many as we would like to have. I would challenge the services if there are informaticists that they align them with the MTFs, not necessarily with us, but they're supporting at the deck plate where those challenges truly exist. And then as far as getting the right resources, starts as a requirement, obviously, through the network. I can't answer specifically when we're going to push those requirements down. What we need to probably do is have the right conversations through the network directors channel to see where we can prioritize that for resources to put against that. With technology really advancing and probably deploying to the MTFs, they'll see more of a need for that, and it should free up other resources. To be honest with you, the return on that should be significant enough. But that's a conversation we probably need to have not only with Admiral Case, the ADHCA at DHA, but also with the network directors. So I'm looking at Colonel Connor to remind me of that when we have the next opportunity, but I appreciate that question. Did that answer it, or did you need more details from Colonel Connor and Dr. Caban?
I think that answers it. Primarily just advocating for all of the CHIOs out there with the similar questions and concerns. Thank you, ma'am.
I'm one of your largest advocates, and I will violently pursue that.
Awesome. Well, thank you so much, Rear Admiral Farrell, Colonel Connor, and Dr. Caban.